Hello everyone. My name is Katherine Kolasa Rocha, and I'm presenting from Edmonton, Alberta, which is Treaty 6 territory where my practicum work also took place. Treaty 6 is a traditional meeting ground, gathering place, and traveling route of the Nahiawak, Anishinaabe, Niitsitapi, Métis, Dene, and Nakota Sioux. My practicum was completed with the Program Innovation and Integration Team, or PI, with Alberta Health Services. The PI team falls under the umbrella of Provincial Population and Public Health within the Division of Screening Programs. It's a cross-functional team providing operational expertise across various screening programs, including lung, colorectal, cervical, breast cancer screening, as well as the Alberta Newborn Screening Program and the Early Hearing Detection and Intervention Program. So the functions of PI include knowledge generation and sharing, project and initiative evaluations, appraisals of emerging evidence with respect to screening programs, liaising with screening-related researchers, and supporting learning and professional development. My practicum placement primarily focused on evidence synthesis and appraisal, supporting the Alberta Breast Cancer Screening Program. So the goal of the Alberta Breast Cancer Screening Program is to reduce the number of breast cancer deaths in Alberta by strengthening cancer screening in the province. Activities of the program include sending letters to Albertans that are eligible for screening, providing screening information, education, and resources both to the public and healthcare providers, and liaising with healthcare providers to ensure that patients with abnormal screening results receive appropriate care and follow-up. My culminating project was broken down into three main activities. Firstly, I assisted with a risk of bias assessment for cohort studies that were included in a systematic review examining the relationship between breast density and breast cancer mortality outcomes. I also completed and presented an environmental scan of high-risk breast cancer programs and guidelines in Canada and internationally, with a focus on how high-risk populations were defined in various jurisdictions. And finally, the bulk of my project was focused on a literature review assessing the evidence supporting the inclusion of specific risk factors for defining a high-risk breast cancer screening population, which is what this presentation will highlight. So in 2022, the Alberta Breast Cancer Screening Program, or ABCSP, published updated clinical practice guidelines with breast cancer screening recommendations, primarily addressing a target audience of asymptomatic women, transgender, gender diverse, and non-binary people at average risk of developing breast cancer. However, there's a subset of people at a higher than average risk that are not fully captured by the existing screening programs and guidelines. So as of 2023, 3 provinces and 2 territories had regional high-risk breast cancer screening programs. While individual high-risk clinics exist in Alberta, there's no overarching provincial program or set of guidelines for this population. So the purpose of the literature review was to summarize the evidence in support of including specific risk factors to define the high-risk screening population and present these findings to a working group comprised of family physicians, radiologists, oncologists, breast surgeons, and a patient representative to inform the development of a provincial clinical practice guideline for this population. Search criteria for the literature review were developed collaboratively with PI and the Alberta Breast Cancer Screening Program team. Relevant systematic reviews, meta-analyses, observational studies, and gray literature was synthesized to highlight evidence regarding the utility of including a variety of familial, clinical, and lifestyle risk factors to define a high-risk breast cancer screening population. The scope was fairly narrow, with a focus on the strength of evidence for specific risk factors and eligibility for high-risk breast cancer screening programs, as the purpose was to inform a guideline outlining best practices rather than for actual program development. Literature focusing on cost analysis, accessibility, health behaviors, and the impacts of social determinants of health on screening were excluded. And we chose to primarily focus on literature from Canada, Australia, the UK, New Zealand, and Europe due to the similarities around the organization of health systems as compared to Alberta. In terms of included studies, academic databases were searched using the previously outlined criteria, and studies were assessed for inclusion. And the primary search was also supplemented with gray literature, literature to be found that was found to be relevant during the previous completion of an environmental scan, and relevant studies found through snowball citation searching. So several key findings emerged from this literature review. Firstly, several strong risk factors for the development of breast cancer were identified. These included the presence of certain genetic mutations that predispose individuals to breast cancer, or a strong family history of breast cancer that could indicate the presence of such mutations. It was noted that many women have not undergone genetic testing, but nonetheless may still have a high risk for familial breast cancer. So we looked at defining what would constitute a strong family history. So a family history of breast cancer in multiple relatives and on both sides of the family, relatives with young onset breast cancer, a family history of multiple other malignancies associated with breast cancer susceptibility genes, and the presence of male relatives with breast cancer were found to that should raise the suspicion of elevated risk. Additionally, women who have undergone chest radiotherapy for the treatment of childhood, adolescent, or young adult cancers prior to the age of 30 were found to have a high risk for the development of breast cancer and should begin screening earlier than the average risk population, starting 8 years following the completion of radiotherapy. One interesting finding was that the contribution of increased breast density to elevated breast cancer risk was controversial. So many studies indicated that women with extremely dense breasts, meaning a high proportion of fibroglandular tissue as compared to fatty tissue, had an elevated risk of breast cancer, with the strength of the association varying between studies. But many of these studies used women with very low density breasts as the comparator group, whereas if you look at the general population, most women have breasts of mixed density. And several studies did not adjust for potential confounders. Nonetheless, there was strong evidence that having dense breast tissue contributes to a masking effect, where breast cancers can be missed on mammography. And there's reasonable evidence to support the use of supplemental screening modalities such as MRI or ultrasound in addition to mammography in this population. Also, several weaker risk factors are found to contribute to breast cancer risk. These included women who are nulliparous or had their first live birth after the age of 30, individuals who had a BMI over 30, those who had an elevated alcohol intake of greater than 1 drink per day, as well as individuals with early menarche or late menopause. While any one of these risk factors in isolation was not enough to define an individual as being high risk, they were found to contribute to an increased risk overall in a multiplicative manner and should be included in risk calculation models. And finally, the literature review addressed the initiation and cessation of screening in high-risk individuals. So it should be noted that many women don't present to their primary care providers with suspicions of high risk, and evidence supports proactive risk assessment in women starting at age 25. So once an individual is identified as high risk, the decision to start screening should be individualized based on how their specific risk factors contribute to risk. So for example, some genetic mutations carry a risk for very early onset breast cancer. And importantly, the decision to initiate or cease breast cancer screening should be part of a shared decision-making model with women well informed of the potential benefits and harms of screening. And risk and screening strategies should be reassessed at regular intervals, with cessation of screening considered when the risk of comorbidity exceeds the risk of breast cancer mortality. So, in summary, several recommendations were made to the working group for consideration in the development of high-risk screening guidelines, including regular proactive risk assessment in primary care, referring women with clear, strong risk factors for high-risk screening for specialist assessment, as well as considering the presence of multiple weaker risk factors in decisions for high-risk screenings or specialist referral, and taking a shared decision-making approach to breast cancer screening in high-risk individuals. The next steps after my departure from my placement are for the working group to use this information and come to a consensus of what will be included in the guidelines. And then the Alberta Breast Cancer Screening Program and PI teams will collaborate to actually draft and finalize and publish these guidelines. Once they're published, further work will be needed for program development, including considerations of accessibility, feasibility, and cost. And finally, I'd like to present some challenges and limitations encountered during my practicum. I found that flexibility and responsiveness to stakeholder needs was key during my placement. So prior to the first working group meeting, the Alberta Breast Cancer Screening Program and PI team and myself had identified a search plan to guide literature review, but working group members highlighted a different set of research questions that were of interest. For example, many primary care providers highlighted the limited time that they had to spend with patients and wanted some clear criteria, particularly with respect to family history that would warrant referral to specialists or medical genetics for a more thorough risk assessment. And in terms of limitations, the narrow scope of both the environmental scan and the literature review meant that topics such as the roles of social dimensions of health, program accessibility, theories of change, and advocacy initiatives in screening programs were not addressed during the culminating report. Finally, I'd like to acknowledge the efforts of my practicums supervisor, Stacey Lockerby with the PI team, and the practicum and culminating course instructor, Margaret, for their support and feedback in finalizing my culminating report, and as well as thank the Alberta Breast Cancer Screening Program and PI teams for creating a supportive learning environment. And now I welcome any questions.